My name is Dan Stein. I'm the medical director of our Inflammatory Bowel Disease Program there at the Medical College of Wisconsin in Milwaukee. We are frequently confused with the University of Wisconsin, but we are in Milwaukee, which is located there. I'm guessing most people in this room know exactly where Milwaukee is, but the Medical College of Wisconsin actually is a private medical school, not to be confused with the University of Wisconsin, which is in Madison. So these are some of my disclosures here too, with some of the different advisory boards and speaking that I do. And this is the program disclosure I believe the CCF wants us to present there too. So the talk that I'm going to talk about is why should you seek out an IBD expert when you have the diagnosis of Crohn's disease and ulcerative colitis, and really, what is unique about that? And so, well, first of all, I think with all the faculty that have done the speaking today, we're invested in the IBD community greater than that. So we're all here taking time out of our lives to come here. We all publish. We're doing research on this, doing publications on this. We're looking for ways for new treatments and the way we can manage our IBD better. And we, most of us see almost nothing but IBD patients all day, every day. We are, Crohn's and Colitis Foundation members, so we've got that going for us too. And we are, almost all of us are training future gastroenterologists on how to manage IBD. So we do a lot of that, and we also are really, really good looking. So please, I put that in because I want to excuse kind of the arrogance here too, is that that we talk about how we're experts in IBD, and it may come off as being somewhat arrogant in that matter, but we're much different than kind of a general gastroenterologist, because our practice is that much different, that we see a lot of things, and I'm going to go through some of the reasons kind of why that is. So just to kind of level set the playing field here too, is I think especially for patients it's often kind of confusing, like how does someone even become a gastroenterologist to start with? Well, and what do you learn about IBD along the way? So you start off by going to medical school after you graduate from college. Med students learn a little bit about IBD. They kind of learn what Crohn's disease is, what ulcerative colitis is. They don't really learn about managing. Then we go through internal medicine training, where we become basically adult doctors, where we can take care of just general type things. You learn more about IBD patients, you manage some IBD patients, but really you're not really involved in those kind of patients. And then you go through 3 years of GI fellowship after that training, okay? And this is where you learn about all GI disorders as well as liver disorders and how to manage that. And you do have some direct care of IBD patients, and you're supervised by an IBD doctor there too. All general GI people pass a general GI board that includes some IBD on it, but it has all the other things like heartburn on it, hepatitis C, all these other kind of things. So you got to learn all of that kind of stuff in addition to IBD, and so you're not necessarily focused on just learning IBD and just managing IBD. And then there are actually an optional fourth-year fellowships for IBD, and we'll talk a little bit about why that can really set someone apart. So what is an IBD specialist? Well, there's really no definition. There's no governing board. There's no regulatory thing. There's no board exam that we take that says, now you're an IBD specialist, like we do when it says, now you're a gastroenterologist. All IBD docs are trained to a different degree. GI doctors are trained to a different degree to manage IBD. There's no board exam, as I mentioned. So, for example, to be a transplant hepatologist, to manage patients with liver transplants, you've got to take a separate board exam. We don't have to do that. There's really no requirement that I have to see a certain number of IBD patients on a given year to say, well, you're still competent to be an IBD expert. And there's no maintenance of certification. So as physicians, in order to maintain our license and our accreditation, we have to do a certain amount of educational credits every year in order to maintain that. And there's no sort of maintenance of certification like there are with other specialties. And then what are we doing now in terms of training? So this is a survey that was done in the United States, asking third-year GI fellows, so people near the end of their training, how comfortable they were at managing certain aspects of IBD care. And you can see here, starting on the left here, that managing inpatient care, the red lines here being the second and third year fellows, so the ones that are really close to practicing on their own, about 80-90% that felt comfortable enough to manage inpatient IBD, kind of straightforward management, But as you see, as you go down, the questions get a little more complicated, where you get patients that have complicated disease. They've got the perianal fistulizing disease. You see the patients that have like pouches, patients that are pregnant, patients that have had surgeries. Now you're getting down to the range where these third-year fellows, only about 30% of them are feeling comfortable managing IBD patients that have had any sort of surgery. So the more complicated the IBD gets, the less comfortable these graduating fellows are. This is another survey study that was done out of Canada. And very similar, you'll see here that the black line here represents what the program director felt was important for these trainees to know about IBD. And the white bars here are what the trainees and where they felt comfortable about their IBD here. And you can see that the numbers here, these correspond to some of the similar things we saw in that last slide, but they're really, some of them are well below even 50%. And again, they saw the same trends. The more complicated the Crohn's disease or the ulcerative colitis, the less comfortable they were. This is also a study, we saw very similar trends like this. This is in the pediatric training for gastroenterology. And the same thing, some of our pediatric gastroenterologists, very few of them, and I highlight here again, these are the third-year fellows, so the ones that are just on the verge of being able to practice on their own. You can see inpatient management, only about 50% of them felt comfortable managing IBD patients inpatient. And you get further down there, you get patients that have a pouch, or they had surgery again. So very similar trends. So the more complicated the IBD, the less comfortable these graduating fellows were with actually managing it. That being said, there is curriculum that is being developed. This is an example of a couple different curriculums out there and suggestions out there for training programs to help best educate our gastroenterologists in managing IBD. So why are some of these GI docs not comfortable with managing IBD patients? Well, medical knowledge is doubling every 73 days at this current rate right now. So that is really impressive. So there's a lot to keep up with. Gastroenterologists that practice a general practice, meaning they see everything from heartburn to hepatitis C, they have to keep up on all of those things, but also IBD. For reference, I suck at hepatology. I am not good at the liver anymore. Because I don't keep up on it like I should. Training programs have a lot of variation, just as I mentioned there. Some training programs, in one of those training programs, some fellows reported they don't actually have a faculty member that is specializing in IBD at their program. So how do they learn to manage IBD when they don't have that available to them? And patient populations vary quite a bit geographically, and also referral patterns from center to center. And so each fellowship training is not identical from one center to another. And this is to give you an example of how much has changed and how rapidly things have changed over time. And you can see here, this is just an approval timeline for drugs that have been approved for IBD. And this is more to illustrate how rapidly things have changed over the past few years. You look from 1950 to 1990, there's 6-7 new drugs that came on board during that time period. Since the 1990 now, we've got 7-8 new drugs that have come out into the IBD space. Okay, that's a lot of new drugs for doctors to learn about and feel comfortable managing. This is another timeline to look at it, and really, once again, you highlight this, that this is just in the last 20 years that we've gotten so many new medications. My prescribing practice is closer to that of a rheumatologist than to a gastroenterologist. I don't prescribe as much antacids and treating constipation as much as I treat, using the biologic therapies and stuff like that, like my rheumatologic colleagues do. So in a lot of ways, our prescribing practices are much different. And, frankly, this is intimidating, we've had, 4 new drugs approved now, and so now that you're out of training and you're supposed to learn this brand new drug, that's intimidating, so they don't always use that. Coming back to what I mentioned about there is a 4th-year fellowship, so you finish your gastroenterology, you can do an extra year. These people are really kind of the wizards of gastroenterology, if I like to say. You know, they've taken upon themselves to do an extra year of training before they go practice independently. They are almost always at a major center of excellence that manages IBD. So they're doing that. They're dedicating themselves to doing more research, particularly during that year, getting their career. They usually are someone who has plans to become, you know, really a premier researcher nationally and internationally. So these are, if you see a physician that has done this, you can be confident that they know what they're doing. So, you know, now that we've talked about, you know, why and what kind of makes somebody an IBD specialist, we want to talk a little bit about kind of some of that self-advocacy. So when you do go to see that IBD specialist here, you know, what do you want to bring to that visit? So how do you optimize your care? So what's important is that, you know, patients that are heavily involved in your care, and I think probably everybody here obviously is taking time out of their Saturday. I think that, you know, they really are heavily involved in your care because you're doing way above and beyond what the average patient would do. So the key is that, you know, you look at the healthcare team that you have, be prepared for your doctor's visit that we'll talk about in the next few slides. Really keep track of that health information. That is so very helpful for at least for me when I see new patients. And get educated about your disease like you're doing today and build yourself a support network. So, you know, there's a lot of times patients are the first thing you do, you get diagnosed with whatever it may be. You're going to go to Dr. Google and search things out there, and there's a lot of stuff that pops up, you know. Kind of, these are some tips here for kind of how do you navigate the information that you're seeing online. You know, look at it whether or not this is somebody's opinion, is it a fact? You know, look and see who the author of the material is and so on. Are there citations and references? You know, the big thing that I put in all caps down here is if they're trying to sell you something at the bottom of it, it's probably not accurate. So I direct all my patients to the Crohn's and Colitis Foundation. Because I think they have the best information there. Again, this shows you some of the other things there too, the American College of Gastroenterology, as well as the AGA has a lot of good things there too. But, you know, don't be afraid to kind of interview your doctor when you show up there, you know. Ask them who's on the team, who his nurses are, how do you reach out when you're sick, you know. This is a nice kind of IBD doctor discussion guide. I'm sorry, this is a little older slide. It still says Crohn's and Colitis Foundation of America on it. But this is a nice way you can walk through before you go into that first visit with the IBD specialist, you know, where you can write down what kind of, you know, what your presenting symptoms were, how you responded to different medications, you know, what the side effects you may have had with a particular medication. These things are all essential that we're going to ask you about. Additionally, you can, you know, find yourself a nice healthcare maintenance chart. You know, I think nowadays we have apps like MyChart and so on that make this a lot easier for you. But keep track of your vaccinations, your medications, other complications you may have had. So also, you know, how do you go in there? How do you know you're seeing an IBD specialist? So you can go ahead and research your doctor online. I think nowadays we all have, you know, pretty reasonable profiles out there. It says where we trained, where we went to school, that kind of stuff too. You know, did we do extra training in IBD? You know, look, see, you know, is there somebody that's recruiting for clinical trials? You know, is this a doctor who's also involved not just in patient care, but also in research? You know, you can go on clinicaltrials.gov and look that up. Do they do research? You know, PubMed is an easy side to go. You can look up people on PubMed there and see how they publish. There actually are 3 DJ Steins on PubMed, and one actually happens to be a gastroenterologist as well. Also, and then are they a member of the Crohn's and Colitis Foundation? I think, you know, docs, there's several different GI societies that we can become a part of, and I think those of us that are members of the CCF are ones that are particularly interested in IBD, not just GI in general. Again, interview your doctor. Like, it's okay to ask questions. You know, I'm not going to be insulted if you say, how many IBD patients do you see? Do you consider yourself an IBD specialist? If not, who in the area thinks, you know, do you consider to be the IBD specialist? You know, I think we all kind of know. I mean, I know who's, you know, the liver specialist that I would send patients to. You know, ask them, do they do research? Did you do additional training? Are you a member of the Crohn's and Colitis Foundation? So does every IBD patient really need an IBD specialist? Probably not. Mild, but in my opinion, I'd say, even mild or kind of uncomplicated IBD patients, probably worth your time to at least go visit an IBD specialist at least once. If you're somebody with IBD that's in remission and you've been very stable on a certain medication for a long time, you probably don't necessarily need to do that. If you've never had any complications of medication, and for example, if you're an ulcerative colitis patient on mesalamine therapy, doing well, you perhaps don't need to see IBD specialists. But who really needs to see an IBD specialist? And this list is actually much longer. And really, I built this list built off those survey studies that I showed you that they had given the graduating GI fellows there too, is that those graduating fellows became less and less comfortable the more and more complicated the patients got. If you're considering a biologic therapy or more advanced therapies, as now we have the small molecules here too. If you're considering surgery, if you have an ostomy or you have a J pouch, a general gastroenterologist is going to be less comfortable than somebody who practices IBD on a regular basis. I think if you've been hospitalized for your IBD, that shows you that you got pretty bad disease, and you probably should at least have one visit with an IBD specialist. Fistulizing and stricturing disease, those were areas on those surveys where the general gastroenterologists were really not very comfortable with managing. So, if you've had multiple complications from being on a medication, if you've had serious infections or malignancies related to this, I think this is important. Or if you have a history of a cancer or history of infection, I think that's important for you to seek out an IBD specialist. There's out there too, if you're considering stopping your therapy, I get patients that will stop their therapy on their own all the time. I think you really, before you make that decision, have that conversation with an IBD specialist. And then anybody, I think, that has more than just GI involvement, people that have rashes or complicated arthritis, I think that complicates the care of your IBD, and I think seeking out a specialist is going to be more comfortable with that. I have a very close relationship with several rheumatologists as well as dermatologists, just because there's so much overlap with that. I joke at our Department of Medicine meetings that I sit at the table with the rheumatologists because I got more to talk about with them than I do with the regular gastroenterologists, and that's no lie. So in summary here, the management of IBD is changing rapidly. It really is difficult, even as an IBD specialist, to stay up on all the stuff that's going on. Don't be afraid at that first visit to, research as well as interview your gastroenterologist. We're not going to be insulted by you asking comments, and asking questions about that. Consider a second opinion, even if it's a one-time deal. Just say, I see patients for second opinions. They just say, my doctor wants me put me on this medication. Is that the right thing to do? And half the times I say, yeah, that's the right thing to do. I do a few slight things different, but not much. But I think it gives you that peace of mind, and then in the end, be a self-advocate. Again, I think all of you being in this room, the fact that you're here on a Saturday morning to learn more about IBD shows that you're all probably self-advocates that know their disease very well. So, and again, remember, MCW is in Milwaukee, not in Madison. So thank you. And I'm not sure if we